I've been so intrigued by these buttons. I've been looking forward to this. Okay. So I've been jotting down notes throughout the day. So forgive me, I'm going to rely upon them pretty heavily. So let's see. So thank you. It's great to be here. I've never participated in an event like this before. I'm learning a lot. I'll tell you a little bit about our organization and the patient populations that we serve and my work there, because I think it informs my approach to the AVS, to the, I guess, ambulatory visit summary. And this is not out of reaction, this is just out of reality, that it will be about 180 degrees different from what Dr. Byrne presented in being low tech, partly by, well, not so much by choice, more by necessity, and with a very high patient-centric focus. So as Andrew mentioned earlier, Central City Concern is an agency, it's a broad-based social service agency whose mission is to provide comprehensive solutions to ending homelessness and achieving self-sufficiency. So we're not a healthcare organization. In fact, healthcare was one of the last things to come to Central City Concern. We have over time adapted our services to meet the needs of that goal of getting people out of homelessness and achieving self-sufficiency. So in that interest, we have a pretty broad array of services. We have about 1,600 units of housing. We do employment services, supportive employment. We do inpatient detox. We do outpatient alcohol and drug treatment. We do specialty mental health. We have a lot of peer services. And then again, one of the last things to be added was primary care. Our patient population is about 60 to 80% homeless, using a fairly broad definition of homelessness, from chronic homelessness on the streets all the way to transitional housing. And about virtually all of our patients are at 100% of the federal poverty level or below. We used to have a 30% uninsured rate. That's now down to about 5%, which is fantastic. I know, it's been a huge couple months. And a really key feature of our organization, and one which makes me feel very humbled and very proud to work there, is about 50 to 60% of our staff self-identify as being in recovery themselves. Many of them are graduates of our programs. The woman who runs our outpatient detox facility, or inpatient detox facility, came in the front door as one of Portland's meanest street drunks 20 years ago, and now runs the facility. It's not just a recovery-based organization. I mean, we do a lot of harm reduction, a lot of wet housing, housing first models as well, but so we have a very broad tent in which to try to care for people. And the patients themselves, again, some of whom are and eventually become staff, do have a high prevalence of mental health disorders, particularly people with severe and persistent mental illness, a high degree of substance abuse. We mentioned homelessness, but also a lot of these social determinants that we spend a lot of time talking about, a primary one being a long-standing history of trauma, of criminality, and of social isolation, which I've found to be one of the most profound things. It's interesting, and what I like about not being in a healthcare organization is it's not my job to fix these things. I can't fix these things. I tried to when I first got to Central City, and I would develop these elaborate plans with inpatient detox, then going to inpatient treatment, and I'd line up housing, and I'd get all these medications lined up for somebody, and then they would get arrested or they would relapse, and I would get so mad because my plan was foiled. And a public health nurse said to me, "Rachel, it's not your job. Your job is not to fix these people. Your job is keep them alive until they're able to make the decisions that will allow them to on their path, that will move them on their path of recovery." And so over time, I've had to learn to be really at peace with this massive messiness and this massive ambiguity in care. And I have to say, I do not envy my colleagues in inpatient medicine, where you really do you have that high level of control, and you're trying to exert that level of control in the transition to the outpatient setting. I guess I have the luxury in a way of being able to tolerate a bit more ambiguity and messiness. And I don't know if you all are familiar with South Central Foundation up in Anchorage, Alaska. So forgive me if you've heard this story before, but Doug Eby up there is their Vice President of Medical Affairs. It's an incredibly visionary healthcare system. It's been a great inspiration in our community in Portland. And Doug Eby tells this story that I think best illustrates this messiness and ambiguity. And it's about the difference between a bird and a stone. And he talks about, I can take a stone and I can throw it at a target. So some people have heard this story. And I can throw it at the target 100 times and I'll get really good at it. And then I take a bird and I try to throw it at that target and I don't have any influence over where it goes. And that's how we think, and that was a very helpful paradigm for me, because we can lean in Six Sigma our way into massive stone throwing all the time. But when it comes to people's behaviors, they're birds. In fact, we often tell ourselves that when a patient's driving us crazy, we have this mantra like, you're a bird, you're a bird, you're a bird. Nothing I can do, you're a bird. So actually, when we embarked on our own sort of lean improvement journey about 5 years ago, we had to ask ourselves, what is our widget? What is it that we're trying to produce? And we realized that our core product isn't to produce visits or to even reduce hospitalizations or even to improve A1Cs. Our core products were to produce hope and to produce safety, in the hope of ultimately influencing the choices that people make. So that's the approach that I take personally, and with my staff as well, with patients, and which will inform the discussion about the AVS. So key things in this, I'm gonna sip of water. One is never to, you can't judge. If you start judging one of these folks when they come in the door, you will lose them. Because a lot of people have been really traumatized by the healthcare system, and my job is to not reenact that. And so we think about one or two things that we want to work on, and even one or two things which at least we're just aware of, and we're just sitting with for a while, that we're not fixing and solving and instructing on. We're just sitting with these for a while. I think it's been mentioned numerous times today, the more changes we make, the less likely we are to be effective. And that I take a lot of restraint and reflection, which is not always successful, to ensure that the goals are the patient's goals and they're not mine. And that often there will be a problem for which we don't have a plan and we don't have a solution. And also that if we do have plans, that if primary care plays a small role, I think that the physician plays an even smaller role, and that there's a pretty robust team, which we've built over the last 10 to 20 years, which involves some traditional roles like a nurse or a pharmacist, but we also do a lot of work with peers, and we have a really robust addictions component integrated into our primary care setting. So I do a lot of work with alcohol and drug counselors. So what do we try to accomplish then if there's all this messiness and ambiguity and sort of multifocality of a visit? What can the AVS accomplish? Well, really the AVS reflects all of the above. It's less a summary of a visit or less instructions than it is a snapshot in time of where this given individual is, what they're hoping for, how I can help, and where we might see things moving over time. How do you accomplish this with an AVS? Well, like I said, we have a very off-the-shelf AVS which doesn't do much. With all due respect, we also have an IT department, which doesn't do much. And so we have a real luxury, I think, of having a lot of flexibility in terms of just what's not encumbering us around the AVS. It does include medication lists. It includes any new medications, any new orders, but the rest is really free text. And I see that, I try to see that as less of a hindrance and more of a place to capture the process and the discussion that the patient and I have had over the course of a visit. So here's how my process goes, and I'll give you a couple of I'll describe it and I'll give you a couple cases and then I'll stop. So I start out by saying, what's important to you today? How can I help? And the patient will list a number of things, and then we try to identify within those group of things what their goals are in achieving what they want to accomplish. And then I spend a little time trying to reframe, trying to check my own understanding. And I also say, you know, I have some goals here too. There's some things that I need to make sure you know, or some things that I feel we need to address. And then I may gather additional data, such as asking additional questions about the problem, doing an exam, looking at the discharge summary if the patient's just gotten out of the hospital. And then we collaboratively develop some sort of plan or some sort of space where we are. And then as far as the ABS goes, in that teach back moment, so what did you understand? I'm typing as we have that discussion. And so it's more when they say, here's what I heard about what I need to do about my swelling in my ankles, I'll write, for your swelling in your ankles. And they'll say I should take this Lasix once in the morning, or if they've gotten it wrong, or if they have a misunderstanding, we'll reframe it in a way that they can understand it. And I type that in as the plan in their own words as we go. And again, as we talk, I try to capture this messiness and where we can't find a solution. And then this wasn't ever a conscious decision, but I found myself at the end of every visit wanting to write down what my expression of empathy or understanding was. Because I feel like at the end of an encounter, you have a thought as a partner in this, you have a feeling, and I want to communicate that to somebody. So I started writing it down. I print it up. It's not beautiful, so I take a marker and I circle what we've talked about. And then I can actually, very often when I'm doing my assessment and plan in my note, I just reference that document. So here's an example, pretty messy. So I was seeing a patient of a colleague whom I'd never met before, and he's a fellow who had a pretty long-standing history of alcohol abuse, from which he'd burned out his pancreas, had developed chronic pancreatitis, and was on chronic opiates to help treat the pain around his pancreatitis. Had been abstinent from alcohol according with our policies for about 6 months. But his history had been that he may get exacerbations of pain, which then trigger a relapse on his alcohol, which then makes him feel more hopeless and suicidal and overusing his opiates, and he ends up in the hospital. Now, unfortunately, all three of these things, his alcohol relapse, his overuse of his medications, and active suicidality, are active contraindications to being maintained on chronic opiate therapy. But if you try to reduce his dose on his opiates, that makes him even more hopeless and he becomes more suicidal. So I was sort of gleaning this in the chart before meeting him, and I was seeing him, having not known him before, to help out a colleague who was away for the day. So kind of messy. So I said, so Pete, or whatever his name was, I said, Pete, you got out of the hospital on Monday, today is Thursday, what happened? And so he explained to me that he'd actually sprained his ankle, which was it was traumatic for him, it was very painful. It triggered an episode of pain over which he felt that he had no control, which led him to overuse his medications, and then he felt guilty and hopeless about that, which led him to drink, and then led him into the hospital suicidal. And he was no longer suicidal. He'd been discharged. He didn't leave against medical advice, and I queried him about that, and he felt safe. So I said, okay. I said, what's your goal today? And he said, I really want to stay sober. I was doing well with my sobriety, and I want to stay on my pain medications. And I said, do you still feel hopeful that you'll be able to do that? And he said, yeah. And I said, do you feel safe around your situation? He said, well, I'm not sure if I'm safe because I think you're going to take away my pain meds. So I did the thing where I said, okay, now, without sort of barreling in with my agenda, I said, let me try to reframe this a bit. It sounds like you have a need for pain management, and you don't know what to do when you have pain exacerbations and it causes you to drink more under stress. And I said, but I have to tell you where I am with this, which is we have a very, very clearly defined controlled substances policy here, and this is in violation of many parts of that. And then I said, so Pete, what do you think we should do next? Which is a hard thing to do because you're now in this power position. I said, what do you think you should do next? And he said the most amazing thing. He said, well, what I'm doing now is clearly not working. And he said, I want to re-engage, he didn't use that term, but I want to get back into, we have an integrated chronic pain and addictions program. I said, I want to get back into that, and I haven't talked to my sponsor in a while, and I want to talk to my sponsor, and I think I need to see my mental health provider again. And we talked about how he would then want to see his primary care provider in about a week. So we did the same thing. After this, he sort of did this problem solving, and I qualified a few things. And then we rediscussed it. I wrote it out in bullet points with him. And then I had to add my own agenda. And I apologize, I don't have this written up for you, so it sounds very verbose. I said, your case, we have a controlled substances review committee, which will be reviewing your case. And to be very clear, you'll find out about that in a week. And then I wanted to add my own thoughts around this. And I just wrote on there, thank you so much for being so honest in our discussion today. I feel that we have, let me find this. Yeah, thank you for having such an honest conversation with me today. I feel like we have a lot of reasons to be optimistic. Bring this good work with you on your next visit to your primary care provider. And so I can't tell him then or there if he's going to get his pain medications, but we have a pretty good plan. It's captured, and but it still engages with that messiness. I have one other case which I want to, I guess I'll try to summarize briefly, in that sometimes with much more complicated medical conditions, I find that we need to be very parsimonious in what we select out and put into an after-visit summary. So this is a patient who has cirrhosis, liver failure from her hepatitis C, and she recently had a massive decompensation of her liver disease and ended up with massive fluid in her belly called ascites, and then a secondary infection of that ascites. Had to get about 8 liters of fluid drained off. She had a lot of new medications. There were family present at the visit. And I had a lot of things on my mind that I wanted to cover. And I asked her first, what did you understand about your hospitalization? And what she remembered was they drained a lot of fluid out of my belly. And I said, well, what do you want to accomplish today? And she said, I really want a hospital bed. I really want to be able to have a drink of water because they restrict her fluids because of how volume overloaded she is. So I talked to her, we sort of talked about what's needed for the hospital bed. I tried to explain this delicate balance between salt and water and liver disease. And I said, and I also got to make sure you know what I'm worried about, which is I want to make sure that you're taking so many new medications that you're taking them appropriately, and also that you know what to watch for so you don't end up in the hospital again. So we worked on those 3 things primarily together. We came up with this idea. We have this unbelievable pharmacy. And I'll just take 10 more seconds, that we would bubble pack all of her medications, that my #1 priority would be to work on her hospital bed. And I said, I don't know any way around having you drink more water. And we spelled that out in our after-visit summary, which I won't go through here, but my powerful sentiment at the end of that visit was, and this is what I write on there, and again, it's not technological, but it's, I think, what we're trying to build. I wrote, I am thinking about you. Take each day as it comes, and I am amazed at your strength.